Could we get people to please sit down so we could begin the program?
We open it from the
Thank you. Come join us. Could I ask people to please sit down? In the second session, we have three speakers, and then we're going to ask the speakers from this morning to come up front so that we can have a time for discussion. We are behind schedule because they came around and told us we could eat until 2, so we'll be running a little bit over, I think. But anyway, let us begin. And our first speaker is Dr. Catherine Loulou, who is Associate Professor in the Department of Family and Community Medicine at the University of Toronto and Director of Global Health Programs. So welcome and thank you.
Thank you very much, and thank you for the organizers for this kind invitation. It is indeed a privilege and an honor to be with you today. I see that the presentation I have in front of me is actually not mine. So I'm going to see if I can find it. I don't know whether there's, I know we're already behind. I need somebody to direct me to my presentation, which was sent yesterday and is not there. I wonder whether Dr. Mcnab would want to go first. I don't mean to overrule the organizers, but I suspect if we're short on time and his presentation is there, then perhaps. I'm sorry, I don't. Yeah, it was because it was right on. Oh, that's Kingsley. This one.
Is the IT person here? There's nobody in the back?
It was just on. So is it this one? Yeah, this is it. So I'll.
Well, she was very fast. We'll see how we're going to do now. Let's try something else. We're going to ask Dr. Scott Mcnab to speak. He's a research professor at Emory University, Rollins School of Public Health in Atlanta, and I think he's also an adjunct professor here at the King Saud, thank you, University for Health Sciences in Riyadh. But I think what's most important is he's trained a whole cadre of MPH graduates from Saudi Arabia. So thank you. And thank you for your flexibility.
Sure. Let me see if we can do this. hang on for a second. Sorry for the IT confusion here. All right. Okay, Assalamu alaikum. It's wonderful to be here. I would like to recognize and honor Dr. Badria and her really fantastic team for the great success that she's had in standing up the Collaborating Center, and also my colleagues and friends who are here. This is the third time that I've been able to present at this important meeting, and I would like to also honor Dr. Asiri, who's a fantastic colleague. At Emory, we host the King Abdullah Fellowship Program, where students come from the Ministry of Health to do their Masters in Public Health, and we've graduated 57 of them so far, who come back now to perform the leadership here in Saudi Arabia. So we're very honored to be here to support His Excellency, and it's wonderful to see the advancement that's been made in this field of science. My area of specialization is in public health surveillance. We published a new book last year, which has this as a component of it as well. So I'm very excited to be here. And of course, this is such an important religious event that happens so regularly, obviously, and the including of the Umrah makes it a very, very important public health circumstance. So we honor the kingdom, and we honor the Ministry of Health, and Dr. Badria and her team who've done a really fantastic job. I'd like to say also that I would like for us, if we could, because this is an important meeting, to be thinking about new ways to solve old problems. And from that point of view, I'm going to present some new ideas, innovative, I think, ideas that may be even disruptive, that address some of the issues that have been raised by previous speakers, especially around public health surveillance, namely post-surveillance activities after the event. But I'd also like to add pre-surveillance activities in this. So let's think about these objectives. Our objectives are the objectives of the Ministry of Health, the Ministry of Hajj, et cetera, to prevent the outbreak of disease by creating a database that contains essential health records of pilgrims visiting the kingdom. So I'm going to ask the question, how can we do that? We know that one of the concerns of medical community here is not having a certainty about the health status of the pilgrims who come. There's very little medical information that's included, et cetera. So let's talk about an innovative way to assist the medical community here, but also to protect the overall health of the pilgrims, plus when they return home. And so we want to talk about the capacity for real-time updates of a pilgrim's hospital record when they happen to become sick and walk into an emergency room. Approximately, I think, 30% of hospitals here in Saudi Arabia have electronic medical record systems, yet those are siloed and not as effective in terms of protection during this event. Then we think about sending alerts to the Ministry of Health in the Emergency Operations Center in Mecca. In 2009, before the Hajj, during H1N1, I led the Centers for Disease Control delegation here to work with the Minister of Health, and we stood up a mobile phone application. There are 14 reportable diseases during Hajj, so the epidemiologist would enter the data of a foodborne outbreak, a respiratory disease outbreak, one of the conditions, and that information was transmitted to the EOC, displayed in a way so the decision makers could determine in real time whether there was an outbreak occurring and what would be the appropriate response for that. The capacity for this still exists. In fact, it has a greater capacity. So alerts to the ministry in terms of what we call case-based surveillance or indicator-based surveillance, if you're into the definitions by the IHR, and even event-based surveillance, which was discussed earlier, so that social networking feeds are screened for events. And how do you apply this to immediate contact tracing, quarantine, and health surveillance? Having worked in West Africa in the wake of the Ebola outbreak, we know that the use of mobile technology for GPS tracking, for workforce activities was really almost singularly responsible, along with the field epi-training program in Nigeria, for keeping Nigeria virtually Ebola-free. So there are proven methods for this. So I'm going to talk to you about what I would call a total solution for monitoring, tracking, alert, and also the actions that need to ensue. And so the first step, I would argue, is country-specific health assessments. When I was just spent a week in Nigeria with the WHO. I think there's something like 150,000 Nigeria pilgrims that come every year. When a pilgrim goes to get a visa for Hajj, in addition to the information collected about their demographic features, their visa number, etc., there's some information collected about health, immunization status, chronic disease status, etc. So that's a pre-Hajj interview that's done in order to get a visa. The medical community here want to be assured that the information that's collected during that pre-visa process is really accurate information, is useful information, and so I'm going to make a case that country-specific health assessments before Hajj is the first step in this process. And that means for the establishment leaders, and we're talking about determining critical indicators. One of the points raised earlier was harmonizing public health surveillance, looking at what information is collected. We know as epidemiologists we're greedy, we want more and more data, but we don't use all that data. So we have to determine precisely what indicators are important to collect during the visa ascertainment process. It also includes what's the burden of disease in the host country, what is the immunization status in the pilgrim's home country. That gives pre-Hajj information available to the Ministry of Health. We'll talk about how that information can become actionable in just a moment. It also can potentially predict the burden of disease during Hajj. If you know who's coming from where and what their pre-existing health conditions are, it gives you intelligence, if you will, intelligence about the health conditions of the pilgrims. So let's talk about the use of smartphones or watches with mobile applications for Hajj establishment leaders. This technology is available, has been used to communicate with the Emergency Operations Center in Mecca, but also to send alerts speedily. If a leader understands that there's a circumstance that the Ministry of Health needs to know about, then this type of technology can provide immediate communication with the EOC. Let's talk about public health tracking solutions. For pilgrims, hospital workers, group travel agents, also the campsite workers, etc. This would be an opportunity for them to be able, we know that when a pilgrim comes into Jeddah to go through customs, they receive a wristband. The wristband, of course, is very useful, and produces an RFID signal, which is captured by the so-called dumb epidemiologists. These are the posts. And the purpose of that RFID signal is for tracking of crowds, but also for security. Very important utility. So the EOC, or the Ministry of Hajj, Ministry of Interior, can watch crowds, make sure that the pilgrims walk safely, and also that there are no undue risks associated with this. Those are two important features, but they do not include health. And my advocacy is they could and should include health. Why not embed or present in a digital format the information that's collected in the visa process for the pilgrim, and put health information in the RFID badge as well, and in a digital format. This would allow for faster responses to emergencies. So when this solution, wristbands are now produced, manufactured relatively inexpensively. For the last several years, they're used to move on the trains from one place to another. Also, they're tracked passively, so crowd movement is monitored, and the protection of the pilgrims during their pilgrimage can be done. They're lightweight, easy to use, and so the RFID chip on them now provides for unique identification of the individual pilgrim, because it has their visa number, their personal ID information, and it contains data by different authorities in the kingdom to manage their movement, transportation, crowd security, and I would say health is the next element that could and should be embedded in the RFID badges. And I'm going to make the case that this, in addition to providing health for the pilgrims, supports the development of infrastructure in the medical community here. And I'll illustrate what I mean by that. So they're allowed access to the metro train right now. So this is, and as I said, they're produced and manufactured relatively inexpensively. If we think about the other capacity here for video analytics using CCTV, there is the ability to proactively take action and protect the pilgrims based on any security threat. So this technology is already existing now, is the point. And the technology for crowd control and security is very appropriate and useful and provides an infrastructure to build upon the potential for health benefits. So let's look at this. The analytics that are available now to do facial recognition are very profound, highest level information technology, in fact. And they provide a way for the Ministry of Interior, the Ministry of Hajj, the Ministry of Health to be able to make sure that the safety of the pilgrims is ensured. They allow detection of overcrowding, provide for facial recognition, and real-time transmission to the control center. So this is not new. This is actually what currently exists. So let's take that also to the fact we've discussed GPS-based tracking, allowing us low-energy Bluetooth and a dedicated wireless network to be able to track where people are at any particular moment in time. This is helpful, again, for the purposes that I mentioned. And the other feature of this, remember that the pilgrims themselves, their leaders, can be communicated with through health messages that go back to these leaders to talk with them about how to wash your hands, to hold your sleeve when you cough. We heard earlier, respiratory illness is the most commonly acquired infection. Teaching the pilgrims how to protect themselves. Also, if there's another alert that's happening, this type of bilateral communication can occur very quickly. And it's very important to be able to involve the public in your surveillance. We talk about this as participatory surveillance in the book that we just published last week. The public is a partner in this. The pilgrims are a partner in this process. Also, developing these easy communication messages to the pilgrims about health and wellness is a very important opportunity. And it can disseminate messages to various parties based on whatever circumstance may arise. If there's a foodborne outbreak, then those who are responsible for the foodborne outbreak should know about that, should know what precautions to take, should also know to alert the pilgrims who are sick to report their disease to the respective emergency room. So what is a solution overview? I'll put it that way. And this is what I think is a very simple graphic which describes the use of RFID embedded health information on the wristbands that the pilgrims already receive. And that information has already been reviewed based on an analysis of the host country's health system, etc. That information then can provide information. If a pilgrim gets sick, they may not speak Arabic. They may walk into an emergency room because they're coughing or have diarrhea. It's just a matter of scanning the badge, creating a digital electronic medical record of the pilgrim, as we would use in our parlance, establishing a more robust, uniform, customized, open source electronic medical record system here in the United States, here in Saudi Arabia, which is something we do not have in the United States right now, actually. So this is something I think that the Global Center for Mass Gathering Medicine can highlight and bring to a place where it can be useful to other countries. This cloud-based application then has the ability to manage the data in a way that protects the individual rights of the pilgrim, protects their confidentiality, but also provides information that's necessary for the command and control center or in Mecca, the place where decisions are made about outbreaks and the distribution of resources and personnel. And so this is the proposed schema for the RFID disease surveillance network, which I think builds upon the existing infrastructure that exists, has a proposal plan to look at thoughtfully what we call door-to-door population health. When a pilgrim goes to get their visa, information is collected based on the application process. When they come back, then the host country also has that information available to monitor and track the circumstances. So the RFID bracelet visits the health facility, as I mentioned, the tap of the bracelet to a reader at the emergency room or the hospital, the data entry form. Let's say, for example, this is one of the reportable conditions here. Then that passive communication of health information can be immediately produced in an active communication using a cell phone or a tablet, reporting case-based information that goes to the EOC, so that captures the value of passive and active public health surveillance. When I was here in 2009, we programmed software to report case-based information about the 14 reportable diseases. Now that information, the disease list, so to speak, has to be reviewed every year, but that information then could be immediately communicated to the EOC so that investigations are done if it's one of the reportable conditions. So you move from passively supporting the EMR system here to an active surveillance activity where the EOC learns that, well, there's an outbreak of foodborne disease that's happening in this particular region. Let's deploy persons to be able to work on that investigation. This is, I think, a potential next step, which would be doable based on the infrastructure that's here and showcase the value of this so-called door-to-door population health. The benefits, speakers this morning discussed integrated solutions. I would make the case that this solution has a number of different benefits. It has the pre- and post-surveillance benefit, which was discussed. It also helps to build the infrastructure here in Saudi Arabia. It also provides information in real time to the Emergency Operations Center so the epidemiologists can identify and know where to go. How many people to deploy, what resources to deploy, and to involve in what we call the investigation processes. These bracelets are not very expensive, and the RFID solution seems to be working very well for crowd control and for also monitoring the security issues. So let's think about what the potential impact of this is, looking at the time when the pilgrim arrives in Jeddah, for example, and in terms of border control, in terms of transportation. These are the features and the advantages that are currently being provided by the bracelets. And we think about the fact that they're given coded personal specific bracelets upon arrival, mentioned that. They're also scanned upon departure, so you know when pilgrims come and when they leave. The name and passport number, basic health data can be linked to the RFID or a similar information communication technology bracelet. That information then allows the pilgrim to walk, to be able to ride the train without pulling out any type of information. It's just a matter of scanning the bracelets. When someone goes to Disney World in the United States, these bracelets are also given to them, so they don't have to carry credit cards. Everything is embedded. You go, your hotel room, the rides, the food services, all of this is provided based on this technology. So this is not just a pie in the sky. This is actually something that does work and function. Our advocacy here is to place public health information on the RFID bracelet based on what's captured during their visa processing. The pilgrim then performs his or her religious act, and the security is maintained by those in control because they can track crowd movements and also make certain that through facial recognition, the public security is maintained. This is already existing and the technology that happens. And then, of course, building access, you have other access to hotels or other types of restaurants, food services, etc., can be maintained there as well. And you can restrict certain areas based on the conditions, whatever the Ministry of Hajj decides. And the actual value of this, I think, is if a pilgrim gets sick and they want to go into the healthcare service, it's just a matter of scanning their RFID badge. You eliminate any problems with language issues. And the electronic medical record system in the ministry is enhanced, built upon, structured based on very carefully determined variables, which is a very important activity that should happen before. What are you going to collect? How are you going to use it? How is it going to be acted upon? That has to be a decision process that is made. And then health practitioners, the physicians who are treating the patient, also have more confidence that the health conditions that pre-existed have been validated, if you will, at the host country, as certain as you can be about what a pilgrim's background is, because that's been done at the very outset. So that helps the medical profession do their performance of their jobs better. In addition, as I said, if there's an outbreak, then Dr. Siri and his team in the EOC has to be able to know where that is, how many people, what the circumstances are. So the communication of the information and a more thorough investigation has to be done. Yep, okay. We're almost finished here. I just want to say that it's such a significant religious experience. The bracelets add to the Pilgrims' experience, and this type of technology of health communication to the providers of the support for the Pilgrims makes it very important. We've talked about crowd control, the value of this in crowd control, and I think that this extends obviously to other places in Saudi Arabia to benefit this, and of course it provides for ultimately, we've talked about the other advantage of this, accommodations, commerce, etc. And I think I'm going to close there, thanking you for the time here. I think that my heart, in terms of thinking about new ways to solve old problems, building upon current infrastructure and thinking about expanding that, is sort of the focus here. And I look forward to talking to the team. Thank you very much.
Thank you very much, Dr. Mcnab. I think it's interesting. Pretty soon I'm going to feel like we're connected to everything by some bracelet or some little gadget that we have on our phone. I'd now like to reintroduce Dr. Catherine Lowe, who's Director of the Global Health Program in Family Medicine at University of Toronto. So thank you. Let's hope.
While my presentation is being uploaded, in the interest of time, let me reiterate my thanks and my gratitude for the invitation. The good news about going after Dr. Mcnab is that, unbeknownst to me, our presentations are actually fairly well aligned. The peril, of course, is that you will recognize some of the concepts again, which hopefully will just serve to feed our collective imagination about what could be as we collaborate further on the organization of health services in mass gathering. Yep, that's it. Good. I must also tell you that this little contretemps reminds me very much of what happens in most mass gatherings I've been involved with, which is you start with a plan and you quickly need to figure out how to change it when things change indeed. Thank you very much. So what I hope to accomplish by the end of this session is to describe how global health principles can inform health services in mass gatherings, but also describe how mass gathering principles can inform global health efforts, and reflect on what I've called Mass Gathering Vision 2050. I am well aware that the wonderful country of Saudi Arabia has a Vision 2030, and that's its own thing. What I'm referring to here is actually something that echoes very much what Dr. Mcnab has just spoken about, and it's an invitation really to think beyond just the mass gathering and think for ourselves what we could contribute to improve the health of the world through our expertise in mass gathering. I have no conflicts of interest, but I thought I'd declare my biases right off the bat. I am Canadian, which means that I am genetically programmed to be apologetic. I won't offer right off the bat an apology, but I will, as I say, comment to the fact that some of my content has strong alliances with what has already been presented and will undoubtedly be developed much further by some of the speakers in the rest of the conference. I'm a family physician by training. I was an emergency physician as well for 10 years, but have not worked in the emergency room for 10 years. And when you're a family physician, if when you're a hammer, everything looks like a nail, when you're a family physician, everything pertains to continuity, comprehensiveness, health equity, and integration. And you'll see this in my presentation. My own experience of the organization of health services in a mass gathering was in the context of World Youth Day 2002. It was a long time ago. World Youth Day, for those of you who are not familiar with the event, is a youth gathering that culminates in an encounter between youth, which is generously described in this case as anybody between the ages of 15 and 35. That's the good news. It's an event that takes place over 6 days and culminates with an encounter with the Holy Father. It changes destination every time it is held, every 2 to 3 years. In our case in Toronto, it included the first few days at Exhibition Place, which is essentially fairgrounds, and it culminated in 2 days at Downsview Park, where the young people actually walk as a pilgrimage 5 to 7 kilometers into the final site, and they stay there for 2 days. So they sleep outside, not in tents, outside between the second to last day vigil and the concluding events the next day. And the final day is open to the broad public, which is why the attendance in our case went from 250 to 1 million. I realize that compared to the Hajj, this is essentially a little garden party, and I apologize for even inferring that I have anything to contribute to your efforts, but I hope that we will at least be able to talk creatively about what the process of organizing mass gatherings might offer us as solutions. The issue about youth is an important one. We've talked and heard about this a little bit today. Because it is a youth event, many times people underestimate what could possibly go wrong. They're all young, they're vigorous, and of course they all behave. And any of you who have youth in your family or who have been youth know that despite the best of intentions, that doesn't always bear out. I don't need to cover the concepts of mass gathering, you're all experts, but I do want to say a word about what is meant by global health, since this is the topic that I was asked to address. There are many definitions of global health. The most widely recognized is one offered by Copeland and Associates in The Lancet in 2009, a surprisingly recent definition of global health. And it speaks to issues that directly or indirectly affect health, that transcend national boundaries, that require global cooperation, that include both prevention and clinical care, that focuses on health equity, that is highly interdisciplinary and beyond health sciences. And you can see already that in that definition is a great deal of resonance with the organization of health services in the context of mass gatherings. So why talk about mass gathering and global health? Well, for most of us, and certainly in my case, when I took on the responsibility of organizing health services for World Youth Day, I looked a little bit like this picture in the tunnel there. I was extremely focused on one event, on 6 days, on those pilgrims, and on that very specific event. But of course, if we step back a little bit, we see that what is represented there by the leaves and the event we're particularly concerned with actually is part of a much greater web, a health system and a human network that goes beyond the first few leaves. And if we pull back again, we realize that globally, this is actually part of a forest of issues, if I can use the analogy, of a number of health issues that are global, that are interrelated and ongoing. As for this strange picture of the pink couch in front of the background, it's there to remind me and you of the fact that what seems like the focus of our attention, in this case the bamboo forest, is for many people on this planet just the background to their day-to-day life. For us, when we organize mass gatherings, they are all-consuming. I had some conversations about that with some other colleagues already. They often are associated with less sleep, less interaction with family, more concentrated meetings and so on. But for the rest of the world is just going about their ordinary business, and they certainly don't think of the events we organize as medical events. And there is on this background, in addition to the background of the lives of the many people we care for, the reality of the large stakeholders. And I've just included here some of the logos of the big movements and trends, if you will, in global health around the world. You see there the UN World Conference on Disaster Risks Reduction, the Sendai Conference, and the declaration that I'll refer to a bit later. Certainly the Sustainable Development Goals, which are the lead and the focus of attention around the issue of health globally. The Integrated Person-Centered Health Services Framework in the bottom corner that really is informing the way health systems are encouraged to be organized. The notion that all of our patients come attached to social determinants of health that very much determine their risks, both during our events and throughout. And of course, there are the priorities of Dr. Tedros and of the WHO, universal health coverage, resilient health system, women, children, and adolescents, the health impact of climate, and a transformed WHO. And while we would, I suspect, all like to ignore all of this and get the work done, I can tell you that as an emergency physician for 10 years, one of my delight in that discipline was to just be able to focus intensely on a given problem, solve what I could solve, and then move on, something very different from the practice of family medicine. The fact remains that our patients are not punctual. Our patients remain individuals both before and after. And this slide represents very much the fact that has been discussed already today, that at the top of the circle is, let's call it event 1, and let's call it one of our large gatherings, and you start with a health needs surge that meets a health system surge that results in a whole new host of health needs and health systems, and that event can go on and feed itself until the persons, in fact, in the middle pink square move on to their other environments, either another country or another event, and then trigger a whole other series of health systems change and impacts. So let's see if I can systematically offer some useful thoughts for consideration. I will say largely for your imagination in terms of how global health and mass gatherings can actually influence each other and inform each other to create ultimately better health systems for the world. I will start with how global health might inform or influence mass gathering health services based on increasing recognition of NCDs, universal health coverage, and equity. And you can see in comparing, you'll see this table twice more. And you can see that there are, again, clear parallels between the two sides. What of equity? Well, equity, for those of you who might not be familiar with the actual definition of the term, is this notion of offering disproportionate services or answering the disproportionate needs of the most vulnerable to bring them to the same level as others. It is different in equity than equity, which means essentially giving everybody the same thing. I think that certainly some of the mass gatherings are ahead of the game in that front, where there is some thought, but there's probably much more that needs to be done. And in fact, Dr. Mcnab's allusion to what happens before is a good example of how we would do well to pay heed to where our patients come from, not just geographically, but socioeconomically, as these will have direct impacts on their risk of falling sick during their travels, as it does for the rest of their activities. Who should we screen? How should we screen? Should we screen for adverse social determinants of health? Is there something we can learn about this that would help us deliver better health services during mass gathering? And should we prioritize the most vulnerables in mitigation, surveillance, and management as we plan for services? It is not rocket science to say that the most vulnerable get more sick. In large gatherings, they are in some cases more likely to attend and others less, but it is a dimension worth considering. What of the non-communicable diseases? And I know there's some upcoming fantastic sessions on that topic. The days, I think, of thinking only about transmission of communicable diseases is well over, if only for the fact that while less dramatic, the fact is that most of the world carries multimorbidity and complexity, even in the youth that travel. And so paying heed to or being prepared to address mental health issues, complex chronic conditions, and motor abilities is something we need to, I think, deliberately think about as we plan for health services. The issue of mental health services in the context of religious experience is, in my very limited and humble experience, one that deserves attention. These experiences generate a lot of both happiness and elation and positive thoughts, but can also be quite anxiety-provoking and lead to some very challenging existential questioning on the part of participants. And we do well, I think, as healthcare providers to ensure that there are the health services to usher pilgrims, but attendees to large gathering across those challenges. And then the issue of universal health coverage, which is, of course, a central element of global health, is interesting in the context of the delivery of mass gathering. It is not an issue at the Hajj, I know, but it is and it can be an issue at other large gatherings. I certainly have heard of large gatherings where, for instance, water is being sold in order to generate revenue, when in fact we all recognize the fact that this is a very good recipe for disaster, particularly for large gatherings that occur outside in the heat. So this is just one example of access not just to health services, but to health promoting supports. The other aspect of universal health coverage, which has been touched on already, is this notion of team-based care. In a perfect world, access to services is access to a team of healthcare provider, both tooled for prevention, care, management. And while this might seem a bit outside of the usual sort of mass gathering, let's get in there with our disaster medicine toolbox, I think it bears mentioning as the world transitions again away from exclusively communicable diseases to chronic diseases. What about a more perhaps reciprocal discussion or contribution between global health and mass gathering? We've talked a lot about the prevention and clinical care, and I want to touch on evidence and innovation, which Dr. Mcnab addressed so well. The notion of messaging and reach within prevention and mitigation is an important one, and I won't say much more about that because I think Dr. Mcnab addressed that very thoroughly in his conversation, in his presentation. I think it behooves us to think about how to harness the prevention and mitigation strategies that we develop both within the organization of health system for mass gathering and those that we are so desperately trying to put in place outside, to actually bring them together and think to ourselves about what a continuum of prevention would look like. Because of course, again, the people who attend our large gatherings most of the time are not large gathering attendees. Most of the time, they are out there in the world, and when they seek medical care or health services, they do so elsewhere, not within our own systems. And one of the, I want to speak to this last notion of clinical care to inform population, which is in a way the flip side of what Dr. Mcnab was presenting, this notion that through the provision of clinical care outside of large gatherings, pre and post, might there not be a way for us to capture some of that pertinent information? Maybe not all of it. We don't need to know if somebody's had an ingrown toenail in 1982, because that is unlikely, although if you're going to walk a lot, perhaps that is irrelevant. But my point is, we don't need to have the detailed medical history of everyone. But what if we could imagine a world where some of that information were available with the patient when they come and see us? And what if that could in turn actually inform our understanding of population health in reverse? I won't belabor the topic of technology. I think, again, Dr. Mcnab has presented this so well. I'll move on. Perhaps I'll say one word, actually, about the innovation in use of health professional. During World Youth Day, we resorted to using level 3 paramedics to oversee the inpatient rehydration of over 120 patients. This was new in Toronto. The notion of a level 3 paramedic was actually a new concept there. It opened the door to a lot more engagement by paramedics in general in the city of Toronto following the World Youth Day. And it's one of many examples, I think, of how we can be creative during mass gathering and allow ourselves to then extend and roll out this notion as we discuss under the rubric of legacy. But there are far many more legacies that mass gathering health services can provide. I think the notion of intersectoriality and interdisciplinary care is an important one, both within the health sector and outside the health sector. I didn't mention there politics, but any of you who've been involved in the organization of mass gatherings have had to learn how to communicate and negotiate with various political stakeholders, not just formal political stakeholders, but let's just call them stakeholders for the sake of argument. I think having an eye on the environment, the politics, the infrastructure are things that we need to carry from the organization of mass gatherings, where the impetus and the urgency is such that it forces us to do it, to carry it much more broadly into our health systems. As I say here, mass gatherings, I think, propel us to find solutions to bridge people in a way we might not otherwise care to do in the day-to-day slugging work of improving our health systems. And so to finish, I want to bring to your attention some of the words of the Sendai framework, for example, which note mass gathering as an opportunity to move beyond emergency response, responding to emergencies to a more comprehensive prevention-based approach to mass gathering management, putting the protection of people's health lives at its center, and that fosters a development of links to other large global instruments, and to begin to think of our efforts during mass gathering as a long continuum of health services for the people we care for. So what would Vision 2050 look like? What could the planning and outcomes of health services for mass gathering look like in 2050? What if we had a truly integrated health system across geography? And I know many of you are thinking, but my own physician doesn't even have an electronic health record. How could this happen? Well, those who organize mass gatherings have shown time and time again that you can go above and beyond what is expected in order to carry out safe services for health gatherings. So let's see what could happen globally. The notion of person-centered, of having data that is pertinent to our patients, to the people we serve, to be able to tie them throughout both pre, during, and post. The notion of being population-informed in our efforts, and again, Dr. Mcnab mentioned that. What if we could minimize linguistic, physical, cultural barriers? And what if we could actually use mass gatherings and the efforts we put into health services, not simply as the avoidance of disaster or mitigation or paramilitary implementation of very important strategies, but as something much bigger, as an effort to essentially improve the human experience globally. This is my last slide. I leave you with these thoughts. I look forward to hearing from some of you about what some of your thoughts might be about the interface of global health and mass gathering. And I look forward very much so, as I step away more and more from mass gathering and closer and deeper into mass gathering in my own career, to hear from your community about how you may contribute to improving the health of populations globally. Thank you very much.
Thank you very much. Our last speaker is Dr. Kinsley Baye, and he is the manager of the surveillance section of risk management unit of the Global Center for Mass Gatherings in the Ministry of Health here in Saudi Arabia. Thank you.
Thank you very much. You're welcome to Saudi Arabia. We are very pleased to have you. We are also hopeful that the discussions and presentations over the next few days will help to shape the mass gathering agenda in the near future. I am going to be talking about the concept of WHO collaborating centers, and then I will talk about the milestones of the Global Center for Mass Gathering Medicine over the past few years. By definition, a WHO collaborating center is an institution designated by the Director General of the WHO to form part of an international collaborative network set up in support of its program at the country, inter-country, regional, interregional, and global levels. This extends to the technical cooperation that the Collaborating Center will give to strengthen country resources and also support national health development. Now, to give some idea of the history of collaborating centers, the collaborating centers even predates WHO. In the era of the League of Nations, national laboratories were also designated as reference centers for standardization of biological products like vaccines. In fact, in 1947, the World Influenza Center in London became a worldwide epidemiological surveillance reference center even before the establishment of WHO in 1948. In 1949, the Second World Assembly declared that the organization should not consider the establishment under its own auspices of international research institutions, and the research in the field of health is best advanced by assisting, coordinating, and making use of the activities of existing institutions. It is this principle that has guided the establishment of the collaborating centers ever since. In the year 2000, the executive board of WHO took it a step further, that centers should begin to have multilateral networks so that you begin to engage each other, exchanging information and transferring ideas, and not necessarily having bilateral cooperation with only WHO. Now, there are procedures for designation and management of the collaborating centers. An agreement has to be established with an independent institution or established with an institution to which an establishment to which an institution is affiliated. And this must be done with due consultation with the national government. Again, the designation, the collaborating center, is purely the responsibility of the technical program head. He reports to the WHO headquarters about the collaborating center. And there is always an agreed work plan between the collaborating center and WHO with clear objectives and way forward. In terms of monitoring is done on a continuous basis. It's usually a program-specific report is sent to the WHO at the end of a task. However, every year an annual report is sent to the WHO. This report will detail the progress made in the implementation of a particular program, and it will also show some of the challenges encountered over the year. At the end of 4 years, there is a formal evaluation of the collaboration by the WHO. It is based on that evaluation that the collaborating center can be redesignated by the WHO. Now, there are different functions performed by WHO collaborating centers. One of them includes implementing WHO mandated work plan, and also they develop and strengthen institutional capacity in countries and regions. Now, there are benefits of designating institutions, benefits for WHO and benefits for collaborating centers. It is an essential and cost-effective mechanism that enables WHO to fulfill its mandated activities, because this way they are able to harness all the resources available to the collaborating centers. It also provides access to the WHO worldwide to use the institutional capacity to ensure the validity of global health works. It also provides opportunity for WHO to lead and shape the international agenda through these global networks. For the collaborating centers, it enhances the visibility and recognition of these institutions, and also provides an opportunity for information exchange and technical cooperation between the collaborating institutions, and provides an opportunity for mobilization of additional resources. Now, I just want to state here that the resources that are mobilized are not part of the agreement for the formation of a collaborating center. It is program-based, project-based, and it's sourced from donor organizations. So it is not a formal arrangement to have a collaborating center, and it will be funded by the WHO. Now, there are over 830 collaborating centers worldwide in 92 countries with several multilateral networks in different fields, even including mass gatherings. As at the first quarter of 2016, there were 5 collaborating centers for mass gatherings worldwide. The first collaborating center for mass gathering was School of Public Health England, sorry about that. It was first designated in 2011 as a collaborating center for mass gathering and high visibility events. But with its current redesignation, Public Health England is now a collaborating center for mass gatherings and global health security. Same with the Flinders University. They are now the collaborating center for mass gatherings and global health security. The University of Washington is a collaborating center for mass gatherings and public health. The Saudi Ministry of Health remains a collaborating center for mass gathering medicine. Why have a collaborating center for mass gatherings in KSA? KSA has invested greatly in this field, as we are all aware. We are at the forefront of mass gatherings. We have gained experience over the years in holding consecutive mass gathering meetings regarding the Hajj and Umrah from 632 AD. KSA authorities therefore have more experience in managing mass gatherings than any other national government. Dr. Saber showed these slides before, but this is where the concept of having a global center for mass gathering medicine in Saudi Arabia was institutionalized. It started with the last Lancet conference for mass gatherings in 2010. After the conference, the Jeddah Declaration was adopted to establish a global center for mass gatherings in KSA. Now, with the adoption of the Jeddah Declaration, the GCC Council of Ministers also endorsed the center, same with the Emerald Regional Ministers and the World Health Assembly. By 2012, WHO set up the Global Center for Mass Gathering as a WHO collaborating center for mass gathering. Now, when the GCMGM was set up, it was affiliated to the Office of the Deputy Minister for Public Health in the Kingdom of Saudi Arabia. The operational base was with the Office of the Deputy Minister for 2 to 3 years. It remained so until 2015, when a substantive Director General was appointed for the Global Center for Mass Gathering Medicine. With her appointment, there was a transition, and the Global Center for Mass Gathering Medicine is now a distinct program under the Ministry of Health with its own budget, personnel, and operational base. Our terms of reference includes evidence-based knowledge management, research and publications in peer-reviewed journals. We establish training programs in mass gathering health, and we advise and consult with the international community to strengthen and uphold national endeavors to develop health plans, programs, and networks. How we work. We try to create a collaborative working environment and coordinating platform with local, regional, national, international stakeholders. We mobilize WHO and its collaborative centers' capacity to ensure knowledge transfer and adopt best practices in the MOH and other relevant health sectors. We utilize modern technologies in the area of mass gathering health and management. Now, to talk about some of our achievements. When the center was initially formed, our focus was mainly on infectious diseases because of the concerns around MERS and other infectious diseases at the time. But over the last 2 years, we have also identified other priority areas, including non-communicable diseases, health promotion, heat illnesses, and our output has increased by 80% over 2 years. We have also published 20 manuscripts in peer-reviewed journals over this time. We have also been involved in a lot of training activities with different collaborating centers as well. We established the first mass gathering track in an MPH program with Al-Faisal University, and some of our staff are teaching in this program already. We have revised and developed the mass gathering diploma program. We have also collaborated with Bournemouth University, United Kingdom, to conduct a major incidents medical management and support training. It is our intention that we will develop national capacity in this area and institutionalize this training program in Saudi Arabia. We have also done public health and disaster preparedness and prevention training. In the area of risk management, after the 2015 incident, we reviewed the Hajj emergency response plan and the pre-hospital triage system. We also did a service availability and readiness assessment of the Hajj. It was based on the findings of that SARA assessment, we were tasked to develop a manpower standard for the Hajj. Now, what happened with developing this manpower standard was that there was an increase in the proportion of healthcare workers that were core health workers at the last Hajj, a 50% increase with that new standard being applied. We also did a strategic health risk assessment for the Hajj. In January, we had a technical consultation on health risk assessment tools for mass gathering in Jeddah. After this consultation, we established a religious mass gathering risk assessment tool known as the Jeddah Risk Assessment Tool. Now, the Jeddah Risk Assessment Tool, although it's supposed to be applied for religious mass gatherings, it has also been useful in other non-mass gathering sectors like the Camel Festival in Saudi Arabia. The Camel Festival attracts over 2 million participants every year. But it was suspended over 2 years because of marriage concerns, because about 30,000 camels also brought in for this festival. Now, the festival showcases the best breed of camels in the kingdom and is held in a predominantly desert area in the kingdom. Now, with that risk assessment, we were able to reprioritize certain hazards that were not zoonoses, such as road traffic accident and scorpion bites. We have done a cholera outbreak risk assessment as well, and we also were involved in monitoring an acute watery diarrhea drill during the Hajj. We have been involved in conferences and meetings within the region and outside. We have published our newsletters. We invite you to become part of these publications as well. We also translated to Arabic the WHO Public Health for Mass Gatherings Key Consideration documents. We have had several collaborations. Some are represented here. We have MOU with the Islamic Bank, Omar Kura University, and Al-Faisal University. We are part of the Vision 2030 project. We have 4 initiatives that have been identified. We want to build institutional capacity and human capacity to deal with the 30,000 million pilgrims that are expected by the year 2030. We need to harness our human resources. Now, medical missions come with their own personnel, and the Ministry of Health also have their own personnel. If we can standardize the registration process of medical personnel, we can harness these resources and redeploy them more effectively, especially in times of emergencies. We need to strengthen our health information system, establish an early warning system for the Hajj, and we also need our systems to communicate more effectively together, speak the same language, sort of. We need to have unified case definitions, and we need to define the data that we can use so that we can plan and make certain decisions, useful decisions with these data. We need to have a continuum of care for pilgrims. This continuum of care is a care pack that will start with the pilgrims in their home country in terms of screening for risk factors, health promotion, and will also end when the pilgrims return home. Like Salim Parker mentioned, there needs to be a minimum follow-up period after the Hajj for pilgrims. This is what we are looking for in the future, and we will only achieve this through stronger partnership with all of you seated here. We invite you to be part of our initiative. Thank you very much.
Thank you to all of our panelists. Now it's your turn. You have a chance to ask questions. But I want to first make a comment, and while we're waiting for our last panelist to come sit up in the front, I think one of the interesting things is that the session that was chosen to be at a university that has a business school, an engineering school, pharmacy school, and a medical school. And we talked about, Dr. Saber talked this morning about how important it was that this is an interdisciplinary approach, that it isn't just medicine or nursing, et cetera. So we have an opportunity to train a larger capacity of people, not just in health, but in security, communications, digital innovations, et cetera. So I'm going to ask the first question, and I'm going to ask, first I'm going to ask Andy, and then I hope Scott will also respond, about the building of the capacity for the workforce for mass gatherings. So, thank you. Are those on? No. I think it's,
It
yes.
is now.
Yes.
Wonderful. So the question has to do with building the workforce for mass gatherings. And the nature of the type of training necessary depends on the role of each individual. So I can envision a continuum all the way from people who need just-in-time training in order to be helpful during a mass gathering and be cognizant of the considerations. And that might take the form of some, very short module kind of training to people who are going to make this, part of their professional engagement, in which case there may be a need for certification or advanced training of a different nature. So I think there is a continuum of training depending on what one's role is going to be in a mass gathering, preparedness and response. In our particular academic setting, I can reflect back at what we did to try and better train our students, our professional degree students, the ones that you refer to as well as others within the university environment. And we proceeded to identify what are the competencies needed in order to be effective. And the topic at the time was emergency preparedness and response, which is an element of mass gatherings. That took the form of developing and offering interprofessional elective courses, offering a certification, as well as working with the schools to introduce content that, we had our fingers crossed that the various schools would adopt that content into their curricula. Now, curricula are very hard to change in some universities. We had success with some and not so much with the other. The final comment I'd like to make about the issue of workforce strengthening is I'm not sure we have a common understanding across disciplines on what are the competencies needed for being effective at preparing for and responding to and delivering on mass gatherings health. Secondly is I think we need some common platforms where it's going to be easy for the individuals to find information in order to get that kind of training. So those are my two calls of action. Thank you.
Scott, do you have something you want to add?
I'm not sure this is working either. First of all, thank you for the question. I would dichotomize this into pre-service and in-service training. At Emory, we've been fortunate to have a collaboration with the Ministry of Health where Saudi physicians come to our university, do a formal master's in public health, and come back here with this sort of pre-service capacity. And I think the establishment of the schools of public health here, the one that you have been responsible for implementing in Asan, one at the King Saud University, and also in the National Guard. These three schools of public health are really important elements of developing what I call public health rising in the kingdom, where you have a public health workforce where their educational achievements are valued in terms of professional development, that the Saudi Health Commission also recognizes an MPH degree in public health as a component of a preventive medicine residency. Then in the in-service, the ability, as he was saying, to develop the competencies for the very specific activities of outbreak investigation, surveillance, management and leadership, etc., are elements that could be developed here. And I guess I would challenge and let us think about new modalities of training. Been involved in developing distance-based learning out of Columbia University in New York and at our university. You could develop here, as we've discussed, a distance-based program that would reach a wide variety of professionals that have different needs and do it in the best pedagogical manner, meaning that you have training programs that people want to come to take. And that they're also credentialed so that when you take them, you can mark it off as a part of your professional development. That means working with the Saudi Commission for Health Specialities to make sure this educational content is valued by them, recognized and credentialed by them. Because you have to think about the full spectrum. It's not just providing the training, but the person who takes the training, is that going to be valuable to them?
Thank you. There's a question over here. I don't know if there's a microphone. My microphone, okay. There's a question over here. Is there a microphone for somebody down in front? All right, maybe you can shout. Oh, this one isn't, I think that's working. So the woman right there. That woman right there needs it. Okay. It's coming. It's coming to you.
Thank you. Assalamu alaikum, good afternoon. I'm Dr. Jawahar Al-Fassam. I'm an emergency medicine consultant. I enjoyed this session very much. Just my comment or a question. If we talk about mass gathering in a stadium or a concert, what is the maximum expected number, and what's actually the number of people in 1 square meter, if the maximum you have? This is the question number one. As Dr. Catherine, this is a comment, nothing is compared to Hajj. The other question is to our Ministry of Health representative.
I just want to respond to the first question because I think
Thank
that's
you.
going to be answered. That's going to be answered. I don't know if you're speaking tomorrow. The day after tomorrow. So 2 days from that, you're going to get a superb answer with all sorts of graphs and all sorts of things.
Regarding?
It'll be, yes.
Regarding the how many?
Regarding how many people you can have in a small space.
Okay. The other question is to the Ministry of Health representative. I'm sorry I didn't get the name. You talked about a center in our country, and I'm really interested in mass gathering, but to be honest, I heard about it, but I didn't know that much details you gave us. So I think communication, or is it new, or just give us a brief history of this center.
Hello. Okay, so the Global Center for Mass Gathering Medicine, if you look at the presentation, we talked about the Jeddah Declaration in 2010, and we also talked about being designated as a collaborating center in 2012. We also talked about the period that we were under the deputy minister. It was an affiliate of the deputy minister's office. It was not until late 2015 that there was a transition from 2016 to this period, where we are now a distinct program under the Ministry of Health, and we report to the Vice Minister of Health. So we have our own budget, we have our own team, we have our own office space, and we have our own projects. Which we have
Are you
highlighted.
training people? Is there an official program or something?
Okay, in respect of training, the Mass Gathering Center is not having a special training center. However, we do support institutions. Like now we have rotations from students from Amakura University, from Alfezo University, from the FETP. You are familiar with the field epidemiology training program in Saudi Arabia. Students come on rotation, have internship to have experience with what we do in the Mass Gathering Center. So this is kind of training, and we also have short courses that we organize in collaboration with universities here in the country and also from abroad.
I think it will be great if you have, some of your people or some of the ER physicians who are interested in such mass gathering thing to help them to get their postgraduate degrees and come back and help you in the same center. I think it will be a brilliant idea.
And this is part of the vision of the center, to progress to a point where we can train people, have a master's program, PhD program, but it's going to be a process. We have started and we are going smoothly, as you can see. So in the coming years, you begin to see these sort of scholarship positions given to people from here to study and come back to develop the capacity in the country.
Thank you very much.
Thank you. There's a couple questions in the front.
Yeah.
Oh, there's lots of people in the front.
Okay, thank you. I'm Chandra Aditama, now representing WHO, but before I worked in Indonesia. I have two questions. Second one is not question. Number one is, Dr. Saber, you show a big, stakeholders of mass gathering. So for Hajj, I'm just thinking, how could we influence the religious leader or religious, ulama, for them also to talk about health on their daily religious practices. Secondly, is regarding the wristband for health information. I just would like to inform you that the day after tomorrow, I will present the data from several countries in Southeast Asia. Then Indonesia already started, they use this one for health card. So the data is in this card. So if there is thinking of wristband, then we should coordinate better. Thank you.
Did you want to respond? Is it working? Thank you.
Anyway, in general.
It's working.
Okay, so I think in terms of the religious leaders' role is very, very important, especially in things in Hajj context. And this is something we've been exploring, because the role of religious leaders in terms of changing behavior and promoting health, especially in health promotion, is very, very important. Sometimes people listen more to religious leaders than doctors. So this is something that we're really trying to explore within the center. And we're starting, first of all, by working with the health missions, but definitely the religious leaders is the next step to find a way to approach them, to engage with them. Conferences like this and collaborations that we're having with the medical missions are very important, and they will go a long way in terms of starting the communication with the religious leaders both within the kingdom. I think it's very important that religious leaders are engaged within the kingdom, but also outside the kingdom in country of origin. Again, a pilgrim from Indonesia will probably listen more to a religious leader from Indonesia. So having that collaboration and engagement is very important, and this is something that definitely we need to work on in the future. As far as Hajj and Umrah and even other mass gatherings, I think a religious leader's role is extremely important. So I agree with you that this is the next step in terms of engagement from the center and outside the center.
You have a question, sir?
Yeah, this is Professor Mahmoud Rahman. I'm from Bangladesh. I'm an epidemiologist. I have some comments to pass, and also you can take it some questions also. One thing is that when we talk about health risk assessment and mitigation, I think this will vary according to the country where the mass gathering is being held. It is the country's capacity which is very much important. We are focusing on Hajj, that's okay, fine, that's most important for us, but there are a lot of other happening in different parts of this world, so that has to be also thought quite well. Talking about the RFID information which has been mentioned, this is very good, this can be introduced, but I think that this will help more on the non-communicable disease, because that past history will be helpful. But for the communicable disease or the infectious disease emerging may not be that much helpful, but it will be helpful to some extent if there is an epidemiological link that from which country they are coming from. So that is a thing which might be helpful, but there has to be some other information also when they are there. So there is another interesting information which has come up here, like constipation is more there from diarrhea, but that is an important issue. I think from my own experience, I can tell that why this is happening, why constipation is more, because could be the toilet facilities are not that very much good, so people don't like to go to the toilets, because that is also needs to be explored well. And also the other issue which we talk about now, the effort globally which is going for joint external evaluation, which the global health agenda and the international health regulation, they have come forward with 19 technical areas together. I think this sort of activities which are happening should be there, that group needs to be involved in, so that the country capacity can be assessed and accordingly action can be taken, so that the country can develop their own capacity to deal with this, all these mass gatherings when this is happening in their countries. Thank you.
Thank you. Could you move the microphone to the man behind you? No, in blue, yes, thank you. And then one more question over here, and this will be the second last and the final one, okay? Thank you.
Thank you very much. Ibrahim Kana from Nigeria. At the risk of repeating the previous question from WHO Indonesia regarding the issue of wristband as presented by Professor Mcnab. Well, I remember in 2014, during the pre-Hajj conference of Heads of Medical Mission, the issue of wristband was part of the resolution, and that member countries were advised to actually develop wristbands so that all medical data of pilgrims will be embedded in. And I found your presentation quite interesting, because that was exactly what you did in my country in 2016, to be specific. And we had bracelets for all our pilgrims, embedded with all the information that you mentioned, actually. You know, and it didn't cost us much. But unfortunately, when we got to Saudi Arabia in the airport, the Saudi security agents actually intercepted and prevented all our pilgrims from using the bracelets for security reasons. And I think this should be revisited, because like you mentioned in your lecture, very elaborate, I found it very interesting. The benefits far outweigh the issues of security. And I want to suggest to the Global Center that perhaps they should take the lead and probably develop the wristbands and give to every country before Hajj, so that the information can be embedded in. Thank you very much.
Do you have a comment?
Regarding wristband, and we will not go into the security issues because our main concerns are the health parts. But regarding having a unified wristband in Saudi Arabia, this is what we are also thinking, because it's not just to get the technology right, which now you have a distinct wristband. The Indonesian have theirs. Now, how do we link these systems together? Because again, after discussing the technology, we also talk about case definitions. How do you define malaria? Do you do it based on symptoms? Is the other person using the degree of parasitemia? If we link this data at that point, that data may not be so useful until we have unified our case definitions, determine the type of data. So this is a basic thing we need to do first before we progress to finding the appropriate technology to link our various systems. Dr. Hani has something to say about the wristband as well.
Who does?
If I could, excuse me, if I could just comment. First of all, thank you for your comment. I was just in Nigeria last week on behalf of the WHO. They were excited about this idea, and also we talked to the new director of the Africa CDC, who has responsibility for the North Africa region, Morocco to Egypt. The point that was made by my colleague is a good one, meaning that this information that would be collected at the time of ascertainment of the visa would be current medical information, immunization history, other non-communicable disease background information, which is important to capture. But if a pilgrim walks into an emergency room with some sort of a condition, let's say a respiratory illness, then the determination about whether that's something that should be reportable as a part of the 14 reportable diseases, moving from passive ascertainment of the data to active case investigation is an important one. Case definitions, all the appropriate surveillance components have to be determined, but that could be quickly moved from passive to active information collection and the movement of the data from, let's say, a tablet, which would be instituted by the epidemiologist after the patient's medical condition has been considered. So there's a transition from passive to active that has to be made, and it's exactly right that the epidemiologists have to be trained in what is the case definition, what should be reported, what's just a normal, case of, respiratory illness that's not associated with any type of outbreak. So that's an important distinction. But I think it can be done. I know that we've done the active part of it here in 2009, instituting smartphones with the 14 reportable diseases software tool, so the epidemiologists do the investigation. That he's pointing to the field epi training program, all the components of outbreak investigation and elements are critical. So,
Okay, there's a comment here, and then the gentleman in black, you are in third row. He's the last question, I promised him. So, Dr. Hani, you have a
Yes, just
comment.
a short comment. And related to the bracelet smart, I just want to say that we have a challenge that we are dealing with more than 100 countries. And unfortunately, some countries, they refuse to wear it. They think it's a matter like, it's for animals, not for a human being to wear it. So there is a lot of things that I should consider as a challenge. It's a beautiful tool that when we use it, it makes our management much easier in the borders and in communication and in transportation. But unfortunately, we're still in developing a method that will be acceptable to everybody. So we can adopt it in that sense. Huh?
Thank you.
Yeah, and by the way, for Ministry of Al-Hajj is the people who are working in developing this and so on. So they are the people who would give more details about how and where the development stage they are reached now. But we are having these problems that you need to do something that suits everybody. More than 100 countries with different cultures, understanding, requirements, and behavior as well. So this is one of the difficulty and challenges that we hopefully we could reach to. Thank you.
Oh, we have one last question. I promised this man, I'm getting a little note saying, you're done, lady. So give this man here, and then you'll have to talk to him. It's nice to see a discussion, though.
Good afternoon. This is Dr. Solas from Turkey. the wristband will be the key point for the future, no doubt. And I totally agree with Dr. Hani, because I had some experiences during my medical background for intrauterine device for the childbirth controlling. People suggested that government is putting something to get intelligence from our family. This is something that the wristband is really something, but as much as you put on the information on this wristband, it might be a danger for the security. If you, first of all, you have to protect the safety of the wristband. If it will be locked, otherwise people may change it. If I don't want to show myself here, I got another one's wristband and they may change their position. Because I graduated from a boarding school, I know how to replace my friend. And if somebody will inform the community that the wristband is not mainly for the health, it is mainly for the security, believe me, you cannot convince any people to use it. For my suggestion, it will be a great progress if it would be held properly and by going step by step. First of all, it should be informed people honestly. On the other hand, you should communicate with the ulama, because in our religion, we have to wash our hands ablution. So that wristband will be water protected. Something else, and at least the ulama says that you don't need to put on the water or we can accept it. This is a real challenging condition, but it will be the good tool for the future. Thank you.
Thank you. I am going to take the prerogative of saying that we should have ended this a while ago. But we started late. So wonderful discussion. And I know there are other people that wanted to comment, but I don't think we have time. So thank you to all the panelists, and join me in thanking them. Thank you. Okay. USB is in there. Is it down?